All right. Thank you, everyone. I'm Eric. I am one of the general surgery residents here at Penn State Health. Thank you to the session moderators and the SAGEs for allowing me to speak. Today I'm going to be talking about transgastric endoscopic retrograde cholangiopancreatography versus laparoscopic transcystic common bile duct exploration for the treatment of choledocholithiasis. Let's see, how do I advance my slides here? There we go. So I have no disclosures personally, but some of the people on my team did, so I'll leave this up for 7 seconds. All right. So as Dr. Holst alluded to this morning, patients who undergo bariatric weight loss procedures have an increased risk for development of choledocholithiasis the greatest within the first 12 to 18 months. And it's believed that 10% of these patients will ultimately go on to develop choledocholithiasis. So typically, endoscopic retrograde cholangiopancreatography, or ERCP, is the gold standard for treatment of choledocholithiasis, followed by cholecystectomy, either that same admission or shortly after. But patients who have undergone Roux-en-Y gastric bypass pose particular issues with ERCP just because of the altered foregut anatomy. So we have two options out of many. We can either approach this transcystically or transgastrically. Both are accepted techniques to treat choledocholithiasis in patients after Roux-en-Y gastric bypass. However, there's little data in the literature, especially in the form of randomized controlled trials, to compare these two. There are some retrospective studies that suggest that the transcystic and the transgastric approaches have similar operative and postoperative outcomes, and the complication rates between the two are similar as well. There is improved operative time in the transcystic approach. Overall, successful stone clearance is reported greater than 90% for both of these procedures. So what did we do? So we wanted to compare these two procedures and look at their operative and postoperative outcomes based on which procedure they underwent. The transgastric group did have to have a history of Roux-en-Y gastric bypass, and they both had to have some aspect of either choledocholithiasis or suspected choledocholithiasis. So we did a retrospective analysis of electronic medical record data between September of 2012 and March of 2023 of patients who underwent transgastric ERCP with a previous history of Roux-en-Y gastric bypass or transcystic approach for the treatment of choledocholithiasis. So our inclusion criteria, transgastric ERCP group had to have a history of Roux-en-Y gastric bypass or we wouldn't have been able to do this study. And previous Roux-en-Y gastric bypass was preferred in the transcystic approach. However, this was not necessary for inclusion. All subjects were at least 18 years of age, not pregnant or incarcerated. And subjects were initially placed into their respective groups based on the planned procedure. I will note that 2 subjects in the transcystic group ended up requiring conversion to transgastric ERCP. So our results, so this is just a snapshot of our demographics. So we had 19 subjects in the transgastric group and 13 subjects in the transcystic group. Groups were similar with regard to age and the rest of the demographics. The only thing that reached significance was that there was obviously a greater number in the transgastric ERCP group that had undergone Roux-en-Y gastric bypass. So cholangitis and acute cholecystitis were more common in the transgastric ERCP group, with cholangitis reaching significance. And the operative time was approximately 40 minutes shorter in the transcystic approach. However, this did not reach significance. However, I didn't include the data in here. However, if I were to take the patients from that underwent conversion to transgastric ERCP and included them in that group, the operative time did become significantly different. Complete stone clearance was achieved in the majority of cases, with similar rates compared to literature. And in these patients, the transgastric ERCP group, the majority of them all of them underwent access to the remnant stomach, which is inherent to the procedure, with only 2 in the transcystic group that required conversion. Gastrostomy tube placement was placed in the majority of patients who underwent the transgastric route, and if they underwent conversion in the transcystic route, they required gastrostomy tube placement. All patients in the transgastric group underwent sphincterotomy, with the majority of them requiring common bile duct stent placement, and we didn't see any of this in the transcystic group. And like I alluded to before, 2 subjects in the transcystic group required gastrostomy tube placement, one for surveillance of a periambulary stricture, and then one due to retained stones. The majority of the transgastric ERCP patients required sphincterotomy and common bile duct stent placement. We had one operative complication that occurred in the transcystic group only, and that was a posterior gastrotomy, and that was in one of the subjects who required conversion to the transgastric approach. When we looked at postoperative length of stay, this was significantly shorter in the transcystic group by approximately 1 day. However, the hospital length of stay was shorter in the transcystic group, although it did not reach significance. And then when we looked at postoperative complications at 30 days, they were similar between groups. And when we broke these down, they were actually similar complications as well. So we had 2 SSIs in the transgastric ERCP group, and then 1 in the transcystic group. And then both groups had 1 patient who required upgrade to the ICU for pulmonary etiologies. And then 1 in the transgastric group actually had a bile leak that actually converted into an abscess. Adverse events, these are minor adverse events which occurred after their operation. These didn't require any procedural intervention, but these were seen significantly more frequently in the patients who underwent transgastric ERCP. And the breakdown of these were all related to the gastrostomy tube. So gastrostomy tube leaks, dislodgements, and any of the sequelae of the leaks, so skin irritation and pain. And one of the patients in the transcystic group that had the gastrostomy tube ultimately had a leak, not intra-abdominally. This was a leak externally that just caused the patient some discomfort. Reoperations, so a significant greater number of reoperations occurred in the transgastric ERCP group, and this was all related to placement of the CBD stent. So most of these patients required CBD stent removal after their discharge, so they had to come back for a reoperation. We also had a few other reoperations in the transgastric group. One had a retained suture bolster from the gastrostomy tube that needed to be removed. One had a bile leak that required a repeat ERCP, and then another one had 2 others had persistent GC, gastrocutaneous fistulas that needed operative takedown. And then 1 in the transcystic group had retained stones that required operative intervention. So the literature comparing these 2 procedures in patients with Roux-en-Y gastric bypass is lacking. However, our data seems to suggest that transcystic approach has several benefits over the transgastric approach. So we saw improvements in operative time, postoperative length of stay, operative adverse events, and then improvements in the rates of reoperation. Unfortunately, transgastric ERCP has a number of inherent downsides compared to the transcystic route that were apparent on our data. So high rates of sphincterotomy and common bile duct stent, increases the risk for postoperative bleeding, and then also these patients will need to come back some point in the future to have their common bile duct stent removed, which adds an additional procedure. And then if they have a stent placed, they need to undergo gastrostomy tube placement. And like I showed before, all of the adverse events were related to this gastrostomy tube placement. So it definitely increases the morbidity that these patients experience. So our data is compelling to suggest that the transcystic approach is superior to the transgastric approach, but we definitely have limitations. So this is a retrospective study, so it comes with all the inherent biases. We have small sample size in both groups. Both of these procedures are pretty rare and aren't performed frequently nowadays. And in the transgastric ERCP group, we definitely had patients with more severe diagnosis. So all of the cholangitis and the majority of the acute cholecystitis patients were in the transgastric ERCP group. So this could skew our data when we're looking at like postoperative length of stay and overall operative times. And then also institutional resources. They may not facilitate the use of the transcystic routes within other hospital systems, so this might be a limitation. So next steps, definitely think randomized controlled trials to investigate both of these techniques in Roux-en-Y gastric bypass anatomy is beneficial. And then possibly this technique could be extrapolated to all patients with choledocholithiasis, not only in the transgastric, or not only in the Roux-en-Y gastric bypass patients. So here are my references. And that's it.
Thank you very much. In the interest of time and getting us back on time, I'm going to ask the old questions to the end, if
Sure.
we do, in fact, have time. Right. I'm going to ask you to move on to our second presentation. Dr. Moyer, thank you. The next presentation is novel intraoperative.